Today we're going to discuss and demonstrate the osteopathic structural exam. There's all kinds of ways to do a structural exam, but today we're going to demonstrate a method that was somewhat perfected by Ed Stiles and often called the Stiles screen or Stiles exam. So we'll talk about that. And the benefit for that is it's great for the primary care physician, even the specialist. It's quick, it's fast, and it reduces the amount of treatment time for you as a clinician in a busy practice. And so with that exam, it's about sequencing out, looking for that key lesion. And Dr. Madden will talk more about how to interpret your findings, but I'm going to just demonstrate the basics of how to on a patient, how I do it every day when I treat patients. And so first of all, in the exam, we start out with evaluating the patient while they're standing or in the standing position. So I've got a willing patient here, and so we'll have him turn around here and face this way. And so we start out evaluating, and we start from the top and work our way down, and not any certain pattern as much as looking for a key lesion and just having a systematic manner of going through it. And so we'll start at the base of the occiput, and if you can see my hands, we'll get more clear about that later, but you're going to start right there between the occiput and C1, and you're going to kind of form a springing motion. Now, I'm a little more advanced in that I kind of go back and forth with my thumb and my finger, but technically you start out, you can kind of take your thumb and you actually feel and you apply a downward, kind of an oblique type motion across that. You're looking for that rotation while you're holding the head, okay? And you go all the way down, don't forget your T1, you can get that too. Then you're going to start the thoracics, okay? We'll use Fryet's laws. The third law, really when you take the body into a flexed or extended position, you restrict the range of motion in the other planes, and so we're going to bring a little bit of side bending and a little bit of flexion, and then we're going to use the hand here to apply a rotation, rotary motion, and grab just the spinous process. We're going to hook them with just our hands, and we're going to feel all the way from the thumb down to the hand. We're going to feel from the thumb to the hand. We're going to be moving and feeling, or listening per se, at the same time. We're going to be moving just like this. You know, he has a band right through here that I'm feeling. I'll keep on going down. He has a little bit of a band right here in the upper lumbars. Then I'm going to take my index finger here, and I'm going to actually spring on that SI, or the SI joint. Then we're going to switch, and same thing here. We're going to do the same motion, and we're going to provide that sequence. Again, he's got some mid-thoracics. On this side, he's got something that goes down in the lumbars again, and then we're going to spring there on the SI. If we find some restriction in this sacroiliac area while I have him standing, I'll go ahead and get a standing flexion test. So I'll sneak around here so you can see. I'll actually get hold of the crest, the PSIS, have him bend forward for me. He's got a little positive there on the left, okay? And keep that data in mind. Then the second part of the screen is to have him go to a seated position. So let me have you walk around here and sit here and face that way for me. Okay, and basically it's the exact same screen, but now we're going to do it in a seated position. Again, we're going to start here. Again, you can do it one side at a time, then switch over and evaluate the other as part of the cervical spine when you go down, or you can do kind of what I do as a little rapid fire where I use my index finger and my thumb to work back and forth. Then make sure you get that T1. It's often missed by students, so they kind of skip over that. Again, you're going to bring that motion in. You're going to feel down that thoracic and lumbar spine. Spring on the SI again. Again, remember, we're dropping the shoulder with a little flexion and adding that rotation. And the key point here is the softer you go, only the key restriction stands out. If you go real hard, you will start feeling the anatomic barrier for every joint, and it will all seem like the whole thing is restricted. That means you're going too hard or you're too heavy-handed. Now, some folks will tell you that my exam does feel heavy, but it's not that heavy. You know, the further you back off, only the key lesions will stand out. Okay, and that's the basic how-to, hands-on way to screen. I did leave out if I have pathology here, then I could do a seated flexion test at the end of my seated screen. And then Dr. Madden is going to discuss interpretation of what data is collected by using this screen.
So, Now what we have to do is interpret the data that we glean from our quick screen. And remember, we're doing it in a standing and seated position. And one of the things we do in a standing position is either include or potentially eliminate the legs from the somatic equation picture. We'll discuss other findings that may clue us in to lower extremity dysfunction as we move through the screen. But remember, by doing it in a seated and a standing position, you can include the legs in the picture and then remove them to assess for changes that you might find. So again, remember, as we do our screening examination, we're springing in a diagonal fashion across the facet joints. We are lateral to the spinous process, medial to the transverse process, and that allows us to grab a nice anatomical hold there as we challenge searching for a restrictive barrier. And remember, as Dr. Jan said, we are challenging or springing at the physiological barrier. We're not trying to establish an anatomical lock where you really lock up the joint. As we begin to spring, remember, the first thing is to take a quick survey and get an idea of where a dysfunction might be. So as I start to include that spring in motion, come right down the right side, right down, and again focusing on crossover points, springing at the SI joint and T1. Move to the other side. And you'll see Dr. Janssen and I clinically use one hand primarily to assess the cervical spine, but I agree with him that you probably want to be a little more deliberate in your initial approach and go from one side to the other. So as I continue to spring, initially I'm just looking for areas of greatest restriction, any area that might be clinically significant. If I need to do a standing forward bending test, do it at that point, and then sit the patient down. And then we're going to go through the same method again and spring top to bottom, looking for areas of restriction. Now, once you've got a gross sense of where dysfunction may be present, now you have to start to interpret the data. Your initial question, remember from the slides, will be top half of the body or lower half of the body. This is very A-B logic oriented to be quick and efficient in a clinical setting, to provide you good, accurate information and develop a treatment plan that you can implement. So once you've determined whether the area of greatest restriction is in the upper half of the body or the lower half of the body, you then continue to fine-tune your interpretation. And remember, we are also looking for clues that would indicate lower extremity dysfunction, such as changes that we might witness going from a seated to a standing position or vice versa. So let's start with the upper half of the body. And if we've got thoracic or cervical dysfunction, that's the next step in the differential process. Let's start with the cervical area. The cervical area will need to be differentiated between upper cervical and lower cervical dysfunction. Again, we're honing in on the area of greatest restriction. If the area of greatest restriction is in the upper cervical regions, you have to ask yourself, is it non-typical cervical mechanics, AA or AO, or is it cranial restriction? We do that by the tissue texture changes that we palpate here at the base of the skull. If you have AA or AO dysfunction, you're going to have some muscular guarding in those upper cervical tissues. As you challenge those joints and try to approach that physiologic barrier, you're going to feel that suboccipital musculature fire or spasm. That's a clue that you might have upper cervical, non-typical joint mechanical somatic dysfunction. If, however, as you approach the physiologic barrier, you begin to feel a dull tissue texture change, as opposed to nice springy tissue, there's just a dull, hard end feel, not necessarily muscle spasm, just abnormally restricted tissue, then you might suppose that there is cranial somatic dysfunction, and I would recommend screening and treating the head. If the area of greatest restriction is in the cervical spine, but in the lower cervical regions, C2 down to C7, then you want to assess those individual segments and treat according to area of greatest restriction based on your spinal diagnosis in that region. If the area of greatest restriction were in the upper half of the body, but in the thoracic region, now we've got a lot of stuff to differentiate between. We've got upper extremity, rib cage, and thoracic spine somatic dysfunction. Again, the tissue texture changes that you palpate as you pick out these areas of restriction will clue you in as to the nature of the somatic dysfunction. If you spring and feel a unilateral band of tightness that's medial to the border of the scapula, then I suggest you evaluate the upper extremity, okay? Especially if it's of a diffuse nature as opposed to an individual segment. If you've just got a band of tightness medial to the scapula, assess that upper extremity. Now, it might be AC joint, it might be SC joint, or it might be on out distal in the radial head, perhaps the carpals, or even the phalanges. Don't forget, it's our hand that makes us human, so it's geared for motion. When it starts to break down, you're going to see evidence of that in the patient's trunk. If, however, you notice a more horizontal band of restriction as opposed to a vertical band of restriction, especially of a segmental nature, somewhere in the thoracic spine, then you have to decide, is it the thoracic spinal column or is it a rib? Now, it doesn't necessarily indicate the key rib, but if you find an area of greatest restriction that's more horizontal in nature, begin to spring in those tissues around the thoracic spine. If you feel the restriction very centrally oriented and just over those facet joints, you've probably got a thoracic spine restriction. However, if you spring, and this is very frequent, you'll be surprised how much ribs are involved, but if you begin to spring lateral along the course of a rib, and you feel more restriction as you spring lateral, then I would recommend treating the rib cage first. Now, we'll have ongoing discussions that prep you for COMLEX. There are certain protocols you follow according to the test, and there are certain protocols that you follow according to clinical practice. We'll try to keep those to a minimum, but in this instance, in clinical practice, if you feel more restriction moving lateral, then more than likely the rib cage is restricted. You need to pause, screen, and treat the rib cage according to your BITE protocol, sequence and treat those ribs, then come back and reevaluate. If, however, it's very centrally located, treat the thoracic spine and then reevaluate. Now, I didn't mention it with the cervical spine, but as with all evaluation and somatic function treatment, after you evaluate and treat a dysfunction, you want to go back and reevaluate not just that area, but the rest of the patient to assess for changes. Because if you want to be efficient, you may get additional bang for your buck by following this area of greatest restriction. And as such, you may wind up having to treat fewer dysfunctions by treating the most restricted areas first. And that's what we mean by being efficient. So once you've eliminated the issues in the upper half of the body, or if the area of greatest restriction were in the lower half of the body to begin with, then you have to begin to assess the lower half of the body. Now, just like with the upper extremity, if your somatic dysfunction is more diffuse in nature, and perhaps if you saw more dysfunction in a standing position that was perhaps relieved when you sat down, i.e. took the legs out of the equation, diffuse band of tightness gets better when you sit down, then you might check that extremity. And again, it doesn't necessarily have to be SI or anominate. It could be out distal in the fibular head or down into the foot. So if you have a diffuse band of tightness, check the extremity. With the lumbar spine, you don't have that rib cage to worry about, but if you have a more horizontal band, especially very segmentally oriented around the thoracic spine, around the lumbar spine, then you want to assess for dysfunction at those segments and treat accordingly. Now remember, as Dr. Janssen and I were taught, group dysfunctions will oftentimes start and be of a chronic nature in response to an acute injury. So if you find a group curve, you may search at the heart of that group curve for a type 2 dysfunction, and again, make your treatment more efficient by really searching for the source of the problem. Now, if as I sprang, or when I did my seated forward bending test or standing forward bending test because I had felt dysfunction in the SI joint region, you have dysfunction in the L5, S1 region, you have to assess, is it L5, is it the pelvis, sacrum, and anominate mechanics that are dysfunctional? And again, as you start to become more skilled with the screening exam, those clues will jump at you ever more easily. But if you have dysfunction right at the SI joint or right at the lumbosacral junction, then you want to really fine-tune your palpation and see which is more restricted. See if there's a difference from sitting to standing. If you have a standing forward bending test and a seated forward bending test that are both positive, then you may want to evaluate the pelvis and fix those mechanics first. Remember, as we continue to progress through diagnostics of pelvic mechanics, we'll discuss the nature of L5 rotation related to the sacrum, and there's lots of things that we need to throw in order to get the correct diagnosis. Remember, if you don't have all the components of a sacral diagnosis, then you need to assess elsewhere, i.e. perhaps treat L5, then re-examine the sacral landmarks and see if all your criteria fit. You guys trust us. We won't steer you wrong with this. It's a very efficient method. It's like Dr. Jan said, not the only method, but it will give you a place to start and a foundation on which to grow and build. Good luck.